Hey guys, welcome to Medifaction. So today we are going to learn about the anatomy of brachial plexus. So let's make it easy and let's get started. So in this video I'm going to enumerate about an introduction about the brachial plexus, followed by the different sections of brachial plexus, which are the roots, the trunks of brachial plexus, the divisions, and also the chords, branches, and we are also gonna talk about the important clinical anatomies related with the brachial plexus. So let's get started. The brachial plexus is a network of nerves that is formed by the anterior rami of the lower four cervical nerves and first thoracic nerve, which are specifically C5, C6, C7, C8, and T1. The plexus extends from the spinal cord through the cervico-axillary canal in the neck over the first rib and into the armpit. So here you can see the C5, C6, C7, C8 and T1. Let's move on to the roots. These are constituted by the anterior primary rami of spinal nerves C5, C6, C7, C8 and T1 with contributions from the anterior primary rami of C4 and T2. The origin of the plexus may shift by one segment either upward or downward, resulting in a prefixed or postfixed plexus respectively. In a prefixed plexus, the contribution by C4 is large and that of T2 is often absent. In a postfixed plexus, the contribution by T1 is large, T2 is always present, C4 is absent, and C5 is reduced in size. The roots join to form the trunks right here. Trunks. The C5 and C6 join to form the upper trunk. The C7 forms the middle trunk all by itself. The C8 and T1 join to form the lower trunk. Divisions of the trunks. Each trunk, that is 1, 2, 3 in number, divides into ventral and dorsal divisions which ultimately supply the anterior and posterior aspect of the limb. These divisions join to form chords right here. Chords. The lateral chord is formed by the union of ventral division of the upper and middle trunk, two divisions. The medial chord is formed by the ventral divisions of the lower trunk with one division. The posterior chord is formed by the union of the dorsal division of all the three trunks, that is, three divisions. Branches. So I know that this was a bit complicated, so to get things easier, I have made a simple modification on the previous diagram and I will teach you in a simple way as possible in the future slides. So now let's learn about the branches before going to it. Branches of roots. Nerve to serratus anterior along thoracic nerve, which comes from the C5, C6 and C7. Nerve to rhomboids is another branch of the roots, which is from the C5 dorsal scapular nerve. Branches of longus colli and scalene muscles. Both arises from the C5 to C8 and branch of phrenic nerve which comes from the C4. Now going to branches of the trunks. These arise only from the upper trunk which gives two branches which are suprascapular nerve from C5, C6 and nerve to subclavius which arise from C5, C6 as well. Branches of chords. Branches of lateral chords are lateral pectoral C5 to C7, musculocutaneous C5 to C7 and lateral root of median C5 to C7. Branches of medial cord. Medial pectoral, which arises from C8T1. Medial cutaneous nerve of arm, C8T1, and medial cutaneous nerve of forearm, also from C8T1. The ulnar, C7C8T1. C7 fibers reach by a communicating branch from lateral root of median nerve, medial root of median, which arise from C8T1. Branches of posterior cord. Upper subscapular from C5-C6, nerve to latissimus dorsi, that is thoracodorsal from C6, C7, C8, lower subscapular from C5-C6, axillary circumflex from C5-C6, and radial from C5 to C8 and T1. In addition to the branches of the brachial plexus, the upper limb is also supplied near the trunk by the supraclavicular branches of the cervical plexus and by the intercostobrachial branch of the second intercostal nerve. Sympathetic nerves are distributed through the brachial plexus. The arrangement of the various nerves in the axilla was studied with the relations of the axillary artery. So as I told, to learn this brachial plexus, I have done some modifications from the previous diagram. So let's make it simple. Let's begin. So as I told, the roots are C5, C6, C7, C8, T1. And when these join together, that is, when C5 and C6 join together, they form the upper trunk. Likewise, C7 all it by itself forms the middle trunk, and the C8 and T1 joins to form the lower trunk. And for forming the divisions, each trunks divide into ventral and dorsal divisions. Here you can see the ventral and dorsal divisions. Now, in order to form the cords, the ventral division of the upper trunk and the ventral division of the middle trunk forms the lateral cord. To form the posterior cord, the dorsal division of the upper trunk, the dorsal division of the middle trunk, and the dorsal division of the lower trunk. All these dorsal divisions joins to form the posterior cord. And to form the medial cord, the ventral division of the lower trunk all by itself forms the medial cord. Now let's learn the branches. To learn the lateral cord branches, I have made a mnemonic LML, where it stands for the lateral pectoral, musculocutaneous, and lateral root of median. Now to learn the branches of posterior cord, I have made a mnemonic ulnar, ULNAR, where U stands for upper subscapular, L stands for lower subscapular, N stands for nerve to latissimus dorsi, A stands for axillary nerve, and R stands for radial nerve. To learn the branches of medial cord, I use the mnemonic 4M and U, where 4Ms are the median pectoral, the medial cutaneous nerve of arm, the medial cutaneous nerve of forearm, the median root of median, and at last U stands for ulnar. Hope you find it easy. Now let's get into some important clinical anatomy. Number 1 is Erb's paralysis. Site of injury. On region of the upper trunk of the brachial plexus is called Erb's point. This junction of where the suprascapular nerve, anterior division, posterior division, nerve to subclavius, and C5, C6 roots comes to join a junction. These 6 nerves meet to form a junction which is known as the Erb's point. So, injury to the upper trunk causes Erb's paralysis. Causes of injury. Undue separation of the head from the shoulder, which is commonly encountered in the following, which are birth injury, fall on the shoulder, and also during anesthesia. Nerve roots involved are mainly C5 and partly C6. Muscles paralyzed here are mainly biceps brachii, deltoid, brachialis, and brachioradialis, partly supraspinatus, infraspinatus, and supinator. Deformity and position of the limb. Talking about the arms, it hangs by the side, it is adducted and medially rotated. And for forearm, it is extended and pronated. The deformity is known as a policeman's tip hand or waiter's tip hand or even porter's tip hand. The disability here are the following movements are lost, which are abduction and lateral rotation of the arm at shoulder joint, flexion and supination of the forearm, biceps and supinated jerks are lost. Sensations are lost over a small area over the lowest part of deltoid. Klumpke's paralysis, site of injury, lower trunk of the brachial plexus. Cause of injury is undue abduction of the arm, as in clutching something with the hands after a fall from a height or sometimes in birth injury. Nerve roots included here are mainly T1 and partly C8. Muscles paralyzed here are intrinsic muscle of hand given by T1 and ulnar flexors of the wrist and fingers given by C8. Deformity and position of the hand. Claw hand due to the unopposed action of the long flexors and extensors of the fingers. In a claw hand, there is hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints. Disability here are complete claw hand, as you can see here, and cutaneous anesthesia and analgesia in a narrow zone along the ulnar border of the forearm and hand. Horner's syndrome. If T1 is injured proximal to wide ramus communications to first thoracic sympathetic ganglion, there is ptosis, meiosis, alhydrosis, enophthalmos, and loss of ciliospinal reflex may be associated. This is because of injury to sympathetic fibers to the head and neck that leave the spinal cord through nerve T1. Vasomotor changes. The skin area with sensory loss is warmer due to arteriolar dilation. It is also drier due to the absence of sweating as there is loss of sympathetic activity. Trophic changes. Long-standing cases of paralysis leads to dry and scaly skin. The nails crack easily with atrophy of the pulp of fingers. Injury to nerve of serratus anterior. It is also known as nerve of Bell. Causes sudden pressure on the shoulder from above, carrying heavy loads on shoulder. Deformity here are winging of scapula. There is excessive prominence of the medial border of the scapula. Normally, the pull of the muscle keeps the medial border against the thoracic wall. The disability coupled here are loss of pushing and punching actions. During attempts at pushing, there occurs winging of the scapula. Arm cannot be raised beyond 90 degrees. That is, overhead abduction is not possible as it is performed by the serratus anterior muscle. Hope you have understood the video. Like, subscribe and press the bell button for more videos. Thank you. Thanks for watching.